Hello and welcome to HealthLine 3. I'm Terry Simmons. Today we're talking with Dr. Robert Martin with WK Piermont Cardiology, and we're talking about coronary interventions. And we'll be taking your calls throughout the show, and as a reminder, please make sure you're in a quiet room with your TV turned down all the way so we can hear you and you can hear us. And the number to call is 318-219-4569, and you'll see it scrolling across the bottom of your screen a little later and throughout the show. So thank you so much for calling and talking to us, Dr. Martin.
My pleasure.
So tell us, again, we're going to start over, and I'm going to ask you the question that we were talking about earlier so that people know that coronary interventions that I learned from you is an umbrella statement or a condition for things that we're familiar with hearing, but this is really good. You're going to explain really what they are as far as interventions.
Correct. So coronary intervention is a broad topic, and it includes any number of techniques or therapies where you try to open a blockage in a coronary artery to enhance the blood supply to the heart muscle.
Okay. And so what are some of those terms that we're probably used to hearing?
You know, originally we called it balloon angioplasty, and from there we developed, science has advanced, and we've come up with stenting, coronary stenting, and so that's, people think of those as the main ones, plain old balloon angioplasty and then coronary stenting.
Okay, and those are two terms that we've heard for a long time, ballooning and stenting. So let's take it really for people who don't know. Ballooning is like what it sounds like, right? Tell us exactly what happens in there.
Okay, so we talked in one of the earlier segments, so someone presents with complaints of chest pain, shortness of breath, and they undergo some testing, and that testing leads to further invasive assessment, and so they come in and have a heart cath done, a coronary angiogram done, and at that time the physician goes through the wrist or the leg and takes pictures of the blood vessels that surround the heart, and that's done in the cath lab. And once they do that, they make a decision on the best way to treat the patient. And some people are best treated with balloon angioplasty or percutaneous coronary intervention, more accurately said. And based on the clinical characteristics of the patient and the characteristics of the blockage or the lesion, you can decide what the best treatment for that patient is, and then apply that treatment hopefully to get the desired result.
And is it is it technically really a balloon? Is it technically that it goes in and expands the artery, or what is the ballooning actually doing?
So most of these treatments do involve a balloon as a first step, and so you gain access across the blockage. So through the tube that you have in the wrist or the leg, the catheter, you manipulate a thin wire across the vessel, and then track another catheter that has a balloon on it across the blockage, the lesion, and then inflate the balloon, and that balloon presses the stenosis, the blockage, and fractures it. And then usually you take that balloon catheter out, and you take a second balloon catheter if you're doing a stent, and this balloon has a stent mounted on it. And so then when you expand that balloon, you deploy the stent and expand it into the blood vessel wall, then you deflate the balloon, remove the balloon, but leave the stent in place, embedded scaffolding, if you will, that holds that vessel open and doesn't let it recoil or close back down.
So just leave something in there that keeps it wide open for the flow to go. What
Correct.
Is the stent made of?
So different materials. Initially they were stainless steel, and now they've moved more towards cobalt, chromium, and other materials.
And does it stay in there forever?
Stays in there forever, yes ma'am.
Okay. And when someone has a blockage, what is it? What's blocking? Is it plaque? Is it something that builds up? What is it that causes a block?
That's right. So a blockage is the buildup of cholesterol in the lining of the heart artery itself. And so the arteries have three layers, and just underneath the superficial layer, the endothelial layer, cholesterol deposits occur. And a number of things contribute to that. And so that cholesterol building up in the lining of the coronary arteries causes the lumen or the channel to narrow, and that creates the stenosis, limits the blood supply. Blood carries oxygen, and so when you're not getting enough oxygen to the heart, sometimes that causes chest pain or shortness of breath. It'd be like if I put a trash bag over your head and you couldn't get any oxygen, you'd scream out for help, you'd cry out for help. And when you're having chest discomfort or exertional shortness of breath, that's your heart crying out that it's not getting enough oxygen.
That's a really good analogy. That's really good to pay attention to what's going on. Do you see people that wait too long? They think, I don't want to make a big deal out of this. I just overexerted myself. Or I don't know why I'm having these chest pains. It'll go away. Do you see people waiting too long?
We do. And you know, sometimes we're too tough for our own good. You know, we push it aside and we go, man, that lasted any longer, I'd have to tell somebody. And so
Right.
we need to be careful if we have risk factors and we have any symptoms to get that evaluated sooner than later.
Okay, yeah, I want to get to those risk factors. We have a call right now,
Okay.
and then we'll get to that. So, Melinda, thank you for calling. What's your question for Dr. Martin?
Well, hello, Dr. Martin. Thank you for being there. What are the different treatment plans for DCM versus CM?
All right. I'm not sure that I heard the question correctly. What I think I heard was, what are the different treatment options between DCM and CM?
Yeah, dilated cardiomyopathy versus cardiomyopathy.
Okay. So dilated cardiomyopathy, as the phrase would suggest, is an enlarged weak heart. And more common terminology is heart failure with reduced ejection fraction. And there are a number of treatments for that. Treatments that have changed that disease and really has provided a lot of benefit. And it's a little beyond our topic today, but the most common cause of heart failure with reduced ejection fraction or dilated cardiomyopathy is blockage in the blood vessels around the heart. And so, you know, like a kid that's not fed, a heart that's not getting adequate blood supply, it's not going to do as well as one that's getting the nutrition, the oxygen, and things that it needs. And so, you know, first and foremost, in patients with heart failure, reduced ejection fraction, you've got to make sure that it's not due to obstructive coronary artery disease or blockage in the blood vessels around the heart. So usually that workup includes a diagnostic cardiac catheterization where you go in and look at the blood vessels. And then based on that and treating that appropriately and getting a few medicines on board, you know, some beta blockers and, you know, some other drugs, there's a list of those that we can really see an improvement in the pumping function with revascularization and the appropriate medical therapy. And there's even some device therapy down the road if those don't result in the desired effect, then there's other things you can do to help. Cardiomyopathy is, she may be thinking about is heart failure with preserved ejection fraction, and that too you have to exclude coronary disease, and there's a list of medicines that help people with that condition also.
Okay. Does that answer your question, Melinda?
Yes, I appreciate that.
Oh, sure.
ma'am.
Thank you so much for calling. And I love when we have the questions from our viewers because they always lead to something else, that whether it's exactly on topic, because sometimes we don't know. We're talking about the heart and some interventions, but it all rolls in together. And it's good to point out that there are other types of heart disease besides blockages, which is what we're focusing on today. Is that correct?
That's correct. And then one of the things that, as I'm explaining things to patients in the office, you know, I'll look around the room and I'll say, you know, our heart's kind of like this room. There's the walls, the pumping function, you know, that's part of the heart. There's the doors, the valves that open and close and let the blood come in and leave the heart. There's the lights, the electrical system of the heart. You can have problems with valve disease, you know, problems with the electrical, problems with and there's the plumbing, you know, the sink we wash our hands in, you know, and that's where the coronary arteries play in. It's part of the overall picture of the heart. It's not the only picture of the heart.
Yeah, I guess it's no surprise when you think about what the heart does to keep us going, that it has all these intricate different conditions and how it functions, just amazing. I think we have another caller for you. I think, Rain, did you call to talk to did I get that correct? Okay. What's your question for the doctor?
My question is, what are the treatments for a leaky valve if it's not real severe in the heart?
All right, that's a good question. So the question is about leaking valves, and just like I mentioned, you know, that would be the door leading into the room. It's supposed to open and let blood flow into the heart and then close and not let blood go backwards. It's supposed to go forward, not backwards. And so when she says a leaking valve, that's sometimes the words we use to communicate to a patient that the valve's not closing as well as we would like, and some of the blood's going backwards. And usually those are initially treated with medications, especially if it's mild, and I think she mentioned if it's mildly leaking, and then they have institute a surveillance type program to where they'll, if it showed up on an ultrasound, they'll set a date to repeat the ultrasound in the future and make sure that it's not getting any worse. Some of these leaking valves can be fixed percutaneously or through the skin, and that's a field that is continuing to develop, and there's new things coming out, new devices, new treatments coming out every year. But that's an area that has a lot of promise in the future. The old days, everything valve problems, if they've got severe, it required open heart surgery to correct the valve problem. But the new advances in the field of structural heart disease, where they're managing these valve problems, has really just blown up, and they're doing so much that's just remarkable to treat both stenotic valves, valves that don't open well, or leaky valves, valves that don't close well. But initially the treatment is usually medical therapy and then some type of surveillance in the future.
Okay. Does that answer your question, Rain?
It definitely did. And I need to know which Willis Knighton, yes it did, and I need to know which Willis Knighton hospital he works at, because I sure would like to visit him.
You want to tell her where to find you?
Right. I'm at Willis Knighton Piermont, and we're in a big medical tower next to the hospital, the Medical Arts Building, Suite 201, I believe. So that's where we're at.
Thank you so much. We'll definitely visit you.
And Rain, did you send us an email earlier asking about leaky valve also?
No, I called yesterday.
Okay, you called yesterday and talked to Bill. Okay, we got your message. I want you to know that we got it. So thank you for calling in and for calling us.
Thank you.
Sure. And so tell us, before we move on to risk factors, let's talk about, have we covered all the different types of coronary interventions? Or we talked about angioplasty. That's probably the most common. Is that true? Or
so, right, regular coronary angioplasty with a stent probably is the most common. But there's a lot of other niche devices that we use, and a lot of it determines on the characteristics of the blockage that we're facing, and there's been a lot of advances in those areas. Sometimes just ballooning the vessel is not enough. You know, the vessel's resistant, and so you have to apply other therapies to get the response that you would like from the vessel. And so they've developed these technologies called atherectomy, where you can go in with a diamond tip spinning burr and drill out this hard plaque that's formed in the vessels. That's rotational atherectomy. They have something called orbital atherectomy, where you kind of sand it off.
Wow.
There's a recent device that Willis Knighton's obtained for us in the last year and a half, and it's coronary intravascular lithotripsy, and that's where you insert a balloon catheter that emits ultrasonic waves, sound waves, and fractures this calcium plaque, the calcified plaque, and that enables the balloons to more fully expand and the stents to more fully expand, and you to get the desired result that you're aiming for the patient.
Wow.
So a lot of neat things that we can do.
It is. It's just really interesting. Okay, we have another caller for you.
All right.
I believe, Tara, do you have a question for Dr. Martin?
Yes, I do. I'm wondering if this coronary artery disease that you're discussing today, is that the same as hardening of the arteries? And whether it is or isn't, is there a way to avoid coronary artery disease?
Great question. So, yes, you know, our parents and grandparents, they would say, you know, mama's got hardening of the arteries, or grandma died from hardening of the arteries. And that's a kind of a local term or expression that describes atherosclerosis, which is the buildup of cholesterol in a blood vessel.
Right.
And atherosclerosis can occur throughout the body. If it happens in our arteries in our neck, the carotid arteries, it can lead to stroke. If it happens in our legs, it can lead to ulcers and poor healing wounds and pain in our legs when we walk. And if it arrives in the heart, it can cause heart attacks and the chest discomfort that we talked about earlier. And so the process of atherosclerosis is the buildup of the cholesterol in the lining of the blood vessel, wherever that blood vessel may be. Today we're talking about the coronary arteries. And so yes, hardening of the artery is a term that people use to communicate this process to their family members.
Can people avoid that? Would a vegan diet do anything toward avoiding it? Or is it just a fact of growing old?
So another great question. Yeah. So it leads to talk a little bit about what the risk factors are. And some of the risk factors for coronary artery disease are unavoidable. It's the hand you're dealt, genetics. Mom had it, dad had it. A genetic predisposition or a family history of heart disease is probably the worst risk factor that there is. And if you have risk factors for coronary artery disease, even in the absence of symptoms, some people merit a cardiac evaluation. But quickly, I talk about, 8 or 9 risk factors for heart disease. And one is, being a man or a postmenopausal female over the age of 50, high blood pressure, sugar diabetes, elevated cholesterol, smoking history, family history, being past your ideal body weight, or not exercising 30 minutes 5 days a week. And so if you've got, it only takes a couple of those, and you can have heart disease. You can't change man or female, what your age is, family history, those things are set. But if you're a smoker, if you're physically inactive, past your ideal body weight, if your cholesterol is elevated, blood pressure and diabetes, those can be treated. Those are modifiable risk factors for coronary artery disease. So there's some work that you can do. There's some ownership that you can take. Some of it's predetermined, but some of it you can impact. And she asked specifically about a vegan diet, and although I'm not a dietitian, there's evidence that a high-fat diet is definitely detrimental. I'm not sure that I can say that a vegan diet would eliminate your risk for coronary artery disease, but there are some favorable studies for a healthy diet and a lifestyle of a healthy diet.
Oh, well, that's a great answer. I appreciate it, and I'm not vegan. I was just using that as an extreme example. I appreciate your time.
Yes, ma'am.
Thank you.
My partner, Dr. Jonathan Davis, is a vegetarian, vegan guy, and so he and I go back and forth a lot about diet, so we have a good time with that.
I'm sure that's a big topic of discussion, especially in the South and this area. Right. A meat eater or not a meat eater, and I know my family growing up ate a lot of meat, and they just can't even understand that. You start with the meat on your plate and then you build around it. Right. So, and I think that's a really interesting. As soon as she said vegan, I thought, yeah, that's that thing that we hear: red meat, red fatty meat. We've always been afraid that causes heart disease, but I really love that you named all of the risk factors, but all the things that you can do, because sometimes we, in the past, before we had people and discussions like this, where you and I can sit down and talk about it, kind of bust the myth, we didn't know anywhere else to go, so we were told, look, if your mom and dad had it, you probably have it too. And we forget that we are still individuals, and even though we may be predestined or we have in our family history, there's all of those things we can still do because you have that even more.
That's exactly right.
And you can kind of, feel like you're changing your DNA. You're kind of doing that because you still are your own individual body. So don't give up and think, I'm just, I'm going to have it, so I'm not going to worry about it. No. And 30 minutes a day, it feels good when people just get out there. You don't have to go to the gym and kill yourself and sweat it out. And, just don't smoke and, drink your water. Just the natural things that, our grandparents always told us to do just to feel good. Don't give up and think that you're destined and there's no trying.
That's right.
All right, and now we have Charles on the line. Hi, Charles. Thanks for calling. What's your question?
Well, the doctor kind of mentioned it, that I go to the gym every day. Been doing it for quite a few years, and I'm 86.
Wow.
And I feel pretty good. And I just wondered, how much exercising should I keep doing? I do like an hour and a half. Nothing strenuous, though. I just do a light workout, and it seems to help me pretty good. Although, I wish I could feel even better, but I don't have any really health issues. But I just wondered about the exercising.
I mean, Sounds good. 86 and
wanting to do more.
want to do more.
You're an inspiration. Thank you so much,
right.
Charles.
I think the recommendations are 150 minutes of aerobic activity a week. And so that's why I usually tell my patients 30 minutes, 5 days a week.
Yeah.
And we're not talking about anything crazy. You know, we're not talking about, I remember P90X. We're not talking about something crazy. We're just talking about aerobic activity, walking, you know, brisk walk, 30 minutes, 5 days a week. And I hear all the time in the office, you know, well, I work and I never sit down and I'm on my feet all day. And I tell the patients, I wish that counted, but that doesn't count. And so, you know, for myself, even though I'm on my feet all day and going from early till late every day, I don't get to count that. It's 30 minutes of sustained aerobic activity 5 days a week, or 150 minutes of sustained aerobic activity. So just being busy doesn't count, unfortunately.
I know.
But it sounds like he's got it.
Yeah, I think, Charles, you're really good about that intentional exercise. It's that intentionally getting out there and wanting to do more. And that's a really good example we were talking about before. The more you do, the more you want to go, because your body loves that. Our natural state is well-being. It wants to do that. So, Charles, what a great example of doing a little more. It feels so good. He wants to do more.
Does that actually help exercise the heart, though?
Yes, sir. Cardiac benefits.
I can't even pronounce that.
That does. It benefits your heart. Everything you're doing, right, is working and benefiting his heart. Did that answer your question, Charles?
Yep.
All right. Thank you so much for calling. You keep exercising. So what else can we do? What can we expect if we undergo a coronary intervention?
So let's say you had symptoms and that led to the heart catheterization, and that defined a blockage that the physician felt was best treated with a coronary intervention. And that's not always the case. Some people have some blockage and they're best treated with medicine. Some people have some blockage and they may be best treated with open heart surgery or coronary bypass surgery. But a percentage of patients, you know, a group of patients are best treated with balloon angioplasty. And so that procedure is oftentimes done the same day, ad hoc, done the same day. Other blockages require you to be brought back and done on a separate day for a variety of reasons. And those, you know, after the procedure, there's certain medicines that a patient has to take, and medicines that are delivered during the procedure and are continued afterwards. And these help address what contributed to the blockage being formed, like cholesterol-lowering medicines, and but also antiplatelet therapy or medicines to help keep blood cells from sticking to the stents or clotting off the stents and having a heart attack. So.
Okay, good. Yeah, I have some more questions about that. We have Lisa on the line for you right now. Hi, Lisa. Thank you for calling. What's your question?
Hi, Lisa. I'm so sorry. Yes, my name is Lisa, and I have a question for the doctor. I've been diagnosed with a leakage, and if I'm saying this right, the left aorta, the left valve. Is it okay? I'm 66. Is it okay to just live with the leakage in the heart, or shouldn't it be addressed?
And a very good question, a question similar to one we talked about earlier, the leaking of a valve. And valves are designed to open and let blood pass through the heart and close and not let the blood come back in the heart. And based on which valve it is, and she mentioned it's her aortic valve, the main valve that lets blood leave the heart. Yeah, lets the blood leave the left ventricle and go to the rest of the body. That one, when it's leaking on a mild degree, is often treated with medication, and that's one that tends to be slow to progress, and so it usually has a pretty favorable prognosis. And that's also one of the valves that has the most evidence about being treated with the new structural devices, the new balloon mounted valves. And so I think if I had just mild leakage of my aortic valve, I wouldn't spend a lot of time worrying about that. I would just keep my scheduled follow-up with my cardiologist, and like I mentioned before, that he'll probably do some surveillance ultrasounds of the heart just to keep an eye on that. And so it'd probably be medicines.
Yes, I had that done a year ago, and as well as the CT scan. and the ultrasound, and you can see the leak, and it's not a small one, but it's worrying me because I'm not on medication for it. I'm not on any statin, and I'm just kind of worried about should it just be left untreated.
And again, I think that the the decision is individualized and based on the other, clinical conditions that you have, your blood pressure and those kind of things, which medicines would be indicated, those things could be discussed at an office visit and make sure that all those things, all those questions were answered.
Okay, so it's not really life-threatening at this moment.
Yeah, if it's mild aortic insufficiency, that's one that usually does not rapidly progress and responds well to medical therapy, conservative therapy.
Okay, great. Thank you so very much,
Yes,
sir.
ma'am.
You have a wonderful day.
Thank you so much for calling. And that's a really good point too. It's always your decision, obviously, to take the medication or not and find out more information. But always good if you're not going to be on the medication to at least monitor it and go to your doctor often and make sure that your decision is still doing okay with your body. Right?
Agreed.
Yeah?
Yes, ma'am.
All right, good. What else would you like? Oh, we have a Deborah. Deborah on the line. Hi, Deborah. What is your question for Dr. Martin?
Hi, how are you? Thank you for taking my call. Yes, doctor. I had a family member a few years back pass away from something called thoracic aneurysm. She had a blood pressure issues all of her adult life, and I have blood pressure issues too. And she was a close family member, and I was wondering, could you explain what a thoracic aneurysm is, and should I look out for that, being that I have high blood pressure?
That's a very good question.
Yeah.
So I mentioned earlier, we talked about, a caller asked about hardening of the arteries. I mentioned atherosclerosis is the process of cholesterol building up in the vessels, and if regardless of where that's occurring, it's detrimental. And so if someone has atherosclerosis of the vessels in their chest, the main vessel that leaves the heart, the aorta, then that predisposes the aorta and the vessels that generate off of it to have issues. And when you couple that with high blood pressure, then under certain circumstances, the vessel walls can be weakened and they can dissect or tear apart. The layers can separate, and that can be tragic, present tragically, and is really a bad condition. The treatment is usually surgical, or although there are some catheter-based therapy for that, the outcomes are not where we'd want them to be. They're very poor, and they use, again, when patients present, they're very ill, and oftentimes an unfavorable outcome is the result.
Okay.
Yes, sir. Yeah, she passed away about 10, 12 years ago, and they had to fly her to Houston, and she survived the surgery a little bit a few days after, but after that, she's already had high blood pressure issues. My mother had all high blood pressure issues, and now I'm diagnosed with high blood pressure issues, so I was wanting to know, so I don't eat like I should, so I, need to try to be up more on that.
I definitely think you should be checked. Controlling your blood pressure would be a very important thing for you, given your family history, and some might even want to do an ultrasound of the heart to make sure there aren't any conditions that predispose to dissection, and maybe even imaging your chest. And so I think that merits an evaluation. Definitely get your blood pressure controlled.
Yeah.
Okay, well that does answer my questions. I thank you for your time.
Sure.
I'm clear about that now. Mm-hmm.
Well, sorry about your family member, and thank you so much for calling. Good luck to you. I'm glad that we got to talk to you.
Yeah, thank you. Have a good day.
You too. Thank you. So, Dr. Martin, we're about to wrap up. So, is there any one thing that you'd like anybody to know really quickly about maybe taking care of themselves, or risks, or?
If you've got some of those risk factors, get checked. We can help you emergently, acutely, but we can help you so much more electively. And so that's what I would say. If you've got those risk factors or any symptoms, get in and get seen.
Yeah, be proactive. Take good care
Correct.
of yourself and ask those questions.
Yes, ma'am.
This has been delightful. Thank you so much. I could talk to you all day about this, so we appreciate you being here.
My pleasure.
And everyone, thank you so much for watching. Thank you so much for our callers for calling in. It's always so helpful when someone calls in. We really appreciate it. So we'll see you next time on HealthLine 3. Have a good day. Thanks again for joining us.